And again, if it's a question you think we've already answered, throw it up anyway, because again, there may be new people here, so it never hurts to go over things again. And long story short, I will continue to do this as long as you guys keep having questions. Without further ado, I'll get started. Like I said, type your questions in the chat box, and after I get done with the ones in my email, I will come to those ones. The first question I got was, can you take sleeping pills while on Cinemet? I mean, the short answer is you can do whatever you want, realistically. Sleep is definitely disrupted in Parkinson's disease, and so a lot of my patients do take medicines, have sleep aids, so on and so forth, everything from melatonin to every other over-the-counter one and prescribed one you can think of. The long story short is, again, they can make you overly tired. Yes, Cinemet can also make you tired. A lot of the medicines that I use in Parkinson's disease or in my patients can make you tired, and so there is an additive effect. I never tell people they can't. I'm not a huge fan of things like Ambien or Lunesta or those kind of medicines, because I find that people, in my experience, people take them and then after they take them, they need them. I prefer to start with things like melatonin. Sometimes I'll use trazodone or Klonopin. I mean, there are prescribed medicines that I'll use. And again, these are really just personal preference. I don't think there's studies comparing one versus another, what's the best for you. But sleep is really important. So if you are having trouble sleeping, make sure you talk to your doctor. There are sleep specialists, so it's not uncommon for me to send my patients to a sleep doctor to make sure there's nothing else that we should do. But the short answer is yes, you can take sleeping aids while on Cinemet. You just have to be careful because they do have an additive effect. The next question that I got was what I recommend next. So that's N-acetylcysteine. And again, this is something that I've heard of from a lot of my patients for a variety of conditions. And if you actually go to the internet and look it up, really, depending on what you read, it fixes everything and all things, which again, I don't think it does. But NAC and N-acetylcysteine and a lot of these supplements are over-the-counter things. And that one I think can actually be prescribed. I kind of have the same philosophy on them. The data that we're going to get is only going to be okay. Nobody's out there doing randomized controlled clinical trials on this type of a thing. And so I'm never going to have definitive black and white recommendations, right? I'm never going to be able to say, here, this is proven, take it, let's see what happens. Do I have patients that use it? Yeah. And so again, I have some people that think it helps, whether or not it's because it's an antioxidant or a free radical scavenger, or it promotes, neurogenesis or what it does. I'm not entirely sure. I don't know if that's necessarily proven. But I liken it to kind of all the other supplements. So my answer sort of for, all the supplements from this to B1 to turmeric and ashwagandha and all the other things that, you will read out there are the cure-alls or potential cure-alls is the same. Is there some scientific rationale or background, which for the most part there is. All of these have brain effects. All of them do something theoretically promoting brain health, nerve health, so on and so forth. Are they toxic? I don't want people taking things that are toxic. And luckily, for the most part, I haven't run into, at least as far as I can remember, any supplement that seemingly was toxic or had things in it that I was kind of questionable or iffy about. And, make sure it doesn't put you in the poorhouse, because some of this stuff gets ridiculously expensive. And when I'm talking about other supplements, a lot of the over-the-counter things, I mean, they can be pretty expensive to buy. And they say, well, you won't really know if it's working for 6 months. And that turns into thousands of dollars that you have to spend on these things. And so again, as long as there's some scientific rationale, as long as there's nothing toxic, and as long as it's not putting you in the poorhouse, I'm not against you trying anything. A lot of these things do have some reasonable science behind them. And the hard part is again, for me to recommend things, there's got to be some pretty solid data behind it, or at least some pretty good data behind it. And those are hard to come by for things like that. So that's kind of my general thoughts on a lot of these different things. I wouldn't say that I would necessarily recommend them, because again, I really do try to hold off recommendations for things that have pretty good data. But again, at the same time, I'm not against you trying them if you want, as long as, those three things are fulfilled. What are the cognitive symptoms of Parkinson's disease, and are there medicines for short-term memory loss to slow the loss? And so that's kind of a two-part question with two-part answer. There's a lot of cognitive symptoms of Parkinson's disease, and especially if you consider the mood things as part of the cognitive things. There's a lot of anxiety and depression, but even purely from a cognitive standpoint, what I do see is just like physically, as you slow down, mentally you slow down too. And that can range from everything from, typical things that I hear with aging. Oh, I walk into a room and I forget why I was going in there. I see somebody, I recognize them, I can't come up with their name. I'm trying to describe something to somebody and I just can't come up with the word. 5, 10 minutes later, it comes to me. I liken that to like a slow memory, right? I know the word, I know the name, it comes to me after a little while. And it goes all the way up to full-blown dementia. There's definitely a dementia that goes along with Parkinson's disease. You can get concomitant Parkinson's disease and Alzheimer's disease. And so there's a range, there's a spectrum. I have plenty of patients that don't have any memory problems or cognitive issues, but I also have plenty of patients that do. The one thing we're not very good at is predicting, okay, you're somebody who's going to go on and develop significant cognitive dysfunction, memory problems, so on and so forth. No, you're somebody who's not. I haven't really seen anything that helps us decide or tips us off one way or another in terms of really being very good at predicting. And so the only thing that really kind of guides us there is time. We just wait and see what happens. Now, the second part's a little bit trickier. And so the question is, are there any medicines or things we can do about that or things we can slow it down? And again, the short answer is I'm not sure. So there's a few medicines that I use for memory problems. You'll see me use medicines like Aricept, Exelon, which is probably my favorite, Namenda, and galantamine. These were all invented for Alzheimer's disease. There's a couple of newer Alzheimer's disease drugs that I'm not going to touch base on because they seem very complicated. I have partners who specialize in cognitive dysfunction. So if I'm getting to the point where somebody needs one of those, I'm definitely sending them to one of my partners. And the data is kind of iffy. So I'm going to leave those new ones alone. But the older medicines that I do use, again, what's the rationale? What's the benefit? I don't think that any of them have really been looked at Parkinson's disease dementia in terms of their benefit. Again, they're all actually proven or thought to be proven for Alzheimer's disease. Now, the caveat to all of these medicines is if you look and see what they actually do in Alzheimer's disease, it makes it even trickier. So the thought process is that the medicines don't actually improve memory or cognition or reverse the problem. The idea is that the medicines kind of prevent it from getting worse or slow down the decline. Now, if you're doing a study and I have 1,000 patients with Alzheimer's disease and I give 500 of them the medicine and I give 500 of them the placebo, you can compare, right? So it turns out that the people that you give the medicine to tended to stay better longer, tended to decline slower, and that's how these medicines got approved. The problem with that line of thinking is how do you know if they're working in any one person? You don't, right? You can watch trends over large groups of people, but in any one person, you never really know if it's doing what we think they're doing. Again, these medicines are supposed to kind of keep you at the level that you're at or slow down you getting worse, but we don't have anything to compare it to because we don't know what you would look like if we didn't give you the medicine. And so that's why it's always tricky with these medicines in terms of, are they helping? Are they beneficial? Are they doing nothing? Again, nothing comes without a price and they all have potential side effects. And so that's where we start weighing out the risks and benefits. I generally do keep my patients on some medicines like that as long as they're tolerating it. With the idea that I don't really have anything better that helps with memory outside of exercise and staying active, which is my favorite topic. And so I do use a lot of these medicines, but are they actually doing what I think they're doing? Or are they actually working? That I'm less sure of. Any insight or known progress with focused ultrasound? I think so. So they're definitely looking at it in Parkinson's disease. They're looking at different targets. They're looking at both sides still, although I had heard that maybe it was approved for both sides. I haven't actually looked it up to see if it is. And so at the end of the day, yes, I think they are making progress with the high frequency ultrasound. For those of you who don't know, there are two procedures or two sort of surgical interventions for Parkinson's disease, particularly tremor predominant Parkinson's disease. One is the deep brain stimulator surgery, which we've been doing here for 20 plus years. The other is something called high frequency ultrasound ablation. And so the long story short is we learned a long time ago that if we put a hole in your brain in a certain location, we can stop tremors. We used to do an open procedure. In fact, I'm pretty sure Michael J. Fox had this done because he mentions it in his book, where they drilled a hole, they would put a probe down, they would burn a hole or freeze a hole, they would take it out. Fast forward to about 6 years ago now, maybe 7 years ago. I don't know, I might be making those numbers up. It turns out that if you aim ultrasound waves under an MRI guidance in a certain area, you can burn a small hole. It has the benefit of not having to require drilling into your skull or putting a hole in you or putting internal machinery in you, which again is very different than the deep brain stimulator, obviously. Initially, there was concerns about doing both sides because of memory problems, walking problems, speech problems, things like that. But I think they're getting to the point where it's much better for that. My experience has still been limited. Again, I don't have one in Pittsburgh. We don't have one at Allegheny Health Network. UPMC doesn't have one. And so the closest places to me right now are WVU. Dr. Ann Murray runs the program down there. She's very nice. I've sent patients to her. And I'm not sure who runs the program up at Cleveland Clinic, but I've sent patients up there too. I think if we can get, and I've asked for this, believe me, I've put it in the suggestion box. I keep getting told no. I'll wear them down though, don't worry. But at the end of the day, since I don't have it readily available to me, I use it much less frequent than the deep brain stimulator, which I have a lot of experience with. We've been doing that here pretty much since I started. And so obviously with a lot more familiarity with it, a lot more experience with it, I'm much more kind of leaning towards DBS. That being said, as it improves, as I get more data, as I send more patients, I will start getting more of a comfort feel with the high frequency ultrasound ablation. And I do think it gives us another option. Again, is it for everybody? No, there's nothing that's for everybody. And you definitely pick and choose who's the right surgical candidate, who's the right ablation candidate, who isn't a candidate for either of these things, who's a candidate for the intestinal infusion. Again, there are other things that we think about, and we generally do it case by case. But the short answer to that question is yes, it is progressing, and it seems like they're heading in the right direction, and more to come on that. I thought this was an interesting one where I have orthostatic hypotension as a result of Parkinson's disease. So that's not terribly uncommon. This is, the receptors that control blood pressure don't function very well in Parkinson's disease. And so when a lot of my patients stand up, blood rushes to their legs, their blood pressure does not correct. In fact, it goes down, and this leads to a lot of lightheadedness and dizziness. What I thought was interesting was they said that I find bright sunlight seems to exacerbate the feelings of lightheadedness when I'm outdoors. Is this due to neurological issues, or are there other patients who have expressed this? I'm not on any blood pressure medicine, but I need to be careful if the weather is too hot. I thought that was interesting. So I have heard that before. Not very common though. But again, there's something that sunlight or going out in the heat can definitely trigger. Again, you have receptors for all of these things. Your body is fairly attuned to changes in environment, changes in temperature, changes in everything. And so and it's all driven by the autonomic nervous system. And so this is the component of your nervous system that really controls automatic functions. So again, your blood pressure, you don't think about your blood pressure. You don't think about your heart rate. These things just happen naturally. Going to the bathroom is sometimes out of your control, but pupil response is also outside of your control, and that's really driven by sunlight. And so these are all part of the autonomic nervous system. And so, when I was thinking about this, I was like, yeah, you can make a connection that maybe there is something that triggers those pathophysiological mechanisms that really is going out in the sunlight or going out in the heat that gives you that same type of response. I don't know that I have any data to back that up or any actual evidence behind that, but when I start thinking about how the pathways work and how the different components of your nervous system work, it does start to make a little bit of sense. And so the short answer is you have to be extremely careful when you go out, and if the weather's hot or if it's sunny, because the last thing you want to do is pass out. That's a terrible idea. That's a surefire way to land in the hospital, which is not where you want to be. The last part of the question was, do you have any recommendations for an automatic blood pressure cuff? And they heard that there was some risk for reading. And the short answer is I'm not the best person for that. They all kind of sound fine to me. I feel like nurses are more in tune to blood pressure cuffs than doctors are because we're not that useful for stuff like that. I've heard that the wrist cuffs aren't always there's finger cuffs too, but I've heard they aren't as accurate as wrist cuffs, which I've heard aren't necessarily as accurate as arm cuffs. Um, a lot of it is positional. So what you're supposed to hold it at heart level. And so there's different things you have to keep in mind when you're using these automatic cuffs. But the short answer is talk to your PCP, maybe take it with you, compare what you get on your cuff to what you get at the doctor's blood pressure cuff, make sure they correlate, and then you're probably good to go. But I don't have one that I think is better than another. In fact, I couldn't name a single brand or a single, specific blood pressure cuff offhand anyway. This one, what I was talking to Christine about was discuss the PONS device. So there's a device out there that actually is tongue stimulation. And I forget what it stands here. I have it looked up here. It stands for portable neuromodulation stimulator. And basically this is a mouthpiece that stimulates different areas of the tongue, and it's been looked at in different things: multiple sclerosis, balance problems, Parkinson's disease. And again, I'm not sure. I haven't gotten a chance to play with one of these devices. I haven't learned much about these devices, mainly because it's so hard to get any of these types of devices in my experience, that it's really hard to make any conclusions without having that type of experience. But there's a lot written about different types of neuromodulation or different types of stimulation, not just from the deep brain stimulator, but if you look in epilepsy, they also have vagal nerve stimulators and other types of nerve stimulators. In headache, they use different types of nerve stimulators. And so we do know that a variety of different ways to stimulate neurons, stimulate nerve cells, stimulate the brain really are effective in a lot of different things. And so I wouldn't be surprised if there is some benefit in Parkinson's disease. But the short answer for a lot of these devices, particularly the ones that we hear about that are available in Europe, getting our hands on them, getting my hands on them to try them in a patient to actually get some experience is really difficult. They're either really expensive or not available in this country, or they're never covered by insurance. And so trying to get these devices has been a really big challenge for me. I'm all for trying them. And again, anything that I can do that's not another medicine added to patients is definitely worth thinking about and worth looking into. But I got to get more experience with these things. I wish there was a better government program or FDA fast track where I could actually get my hands on these things sooner, quicker, and more readily available, because I really do think there's something to these things and being able to help more patients. And I feel like either cost or availability are really big roadblocks for a lot of things in this realm. It's very frustrating, not just for patients, but for me and everybody. I think if there was an easier way that we could get a hold of these things, I think you'd see better use of them. And I really do think they have a room for helping people. But until I can get my hands on them, until I can get more readily available things, until I can try them and see what the end result is, the best I can tell you is what I read online, and that maybe they are helpful, but more to come, hopefully. This was another little bit off topic, but I'll touch on it briefly, which was because you talk about transient global amnesia. Again, they know it's not Parkinson's disease or a movement disorder. So at the end of the day, I'll only touch base on this briefly, but it's actually not an uncommon thing that we run into in neurology. Usually we see these patients in the hospital, and it's exactly what the words mean. So transient meaning it's temporary, global amnesia is you can't remember anything. And this is kind of, one of the interesting things in neurology, where these patients show up in the emergency room and they can't remember anything. Basically, they keep asking the same questions over and over again. How did I get here? What's going on? What's the problem? You tell them 5 minutes later, how did I get here? What's going on? What's the problem? I remember one patient that I saw in the emergency room, and I had my purple shirt on. 7 times they said, "That's a really nice purple shirt. I like that." Now, I felt good about it because I liked my shirt, but at the end of the day, that's the idea. And the brief answer, because I know this is a bit off topic, is we don't quite understand the mechanism. There's something in the hippocampus that basically shuts down your ability to create memories. It's not necessarily vascular. It's not necessarily epileptic or seizure-like. We're not entirely sure what it is, but something basically shuts down your brain from creating memories for a period of time, usually up to a day, not usually longer. We don't usually treat it like stroke, meaning we don't put you on like aspirin, although sometimes we do. We don't usually treat it like seizure or put you on anti-epileptic medications. It's usually a one-time thing, and you never get those memories back because you literally did not form memories during that time. And so that's really the long and short of it. It is something you should follow up at least once with a neurologist just to make sure you're doing okay. But it's one of those fascinating things in neurology that really makes people like me go into this field because the brain is so complicated. It's so fascinating. And you see conditions like this that really we're not very good at explaining, but are just super interesting. That's all I'm going to say about that. All right. I think we got maybe one more here. I think. All right. I've been biting my tongue on the side of my mouth and I can't get it to heal. Also, I've been tapping my teeth periodically, like rhythmically, and I think it's due to Parkinson's, but wasn't sure. Well, if you've ever listened to this talk before, basically literally anything can be Parkinson's. Everything, anything, all things. Teeth chattering, tongue biting are not common things that I get, but they're not uncommon either, because there's a couple things that could be directly related to Parkinson's. So one is you can get a tongue tremor. I've actually seen a patient initial presentation is a tongue tremor. Not very common, but definitely can happen. A lot of people have mouth and jaw tremors, particularly as things progress. And you can imagine as your jaw is tremoring, you can definitely bite on your tongue. So if you are having a mouth tremor, a tongue tremor, a jaw tremor, that can definitely lead to tongue biting. And again, I think everybody on here recognizes that once you bite your tongue, you keep biting it. I feel like that happens to me when I bite my tongue too. And so that does prevent healing, especially if you continue to have a jaw tremor and you continue to bite your tongue. The other thing that can give you rhythmic movements in your tongue is dyskinesia. So it could theoretically also be a side effect of your medicine. People, especially, with too much medicine, not only do you get squirmy movements, but you can get mouth movements, you can get tongue movements. You definitely see this more commonly in tardive dyskinesia, which is usually an antipsychotic thing, but you can get tongue movements and face movements in Parkinson's disease dyskinesias too. And so that would be another thing with abnormal movements in your mouth and tongue that could definitely lead to continually biting your tongue, repeatedly biting your tongue and not allowing it to heal. So how do you figure this out, or what do you do about this? Well, much like everything else that I always tell you guys is paying attention to timing. When is it happening? Particularly not just time of day, but in relationship to your medicines, if you're on any, right? If it turns out that 2 hours after you take your pill, that's when you're biting your tongue, then it's more likely a dyskinesia. If it turns out that as your pills are wearing off, you're more likely to bite your tongue, it's probably a tremor or a more Parkinsonian feature. And these are important when you're trying to figure out what to do about it. Now, outside of be careful, don't bite your tongue anymore, trying to see would adjusting your medicines or would be doing something different be helpful. I mean, the best way to try to figure that out is to try to see if there's a pattern to it, try to see if it correlates with any of these things, and then adjusting accordingly. If it doesn't, then we may just have to kind of watch it, see how you do. But I'm not sure there's a better solution for that. Again, tongue biting repeatedly, I can't say that's a common thing that I get or a common complaint that I get in my office, but I could think of ways where you could get that, and I do think it could make sense. All right, let me scroll back up here and start talking about some of these questions here. Keep throwing them on there. I'll do my best to answer as many as I can. All right, alcohol consumption when on Parkinson's disease medicines. Well, I am never one to tell people they can't drink. Alcohol is not great for your brain, certainly not great for your nervous system, but at the end of the day, I'm not here to tell you what you can and can't do. This is America. You're allowed to make your own decisions. However, when you're on Parkinson's disease medicines, my experience has been alcohol hits you harder. So if you're somebody who used to be able to go out and have a few glasses of wine or a couple of mixed drinks or a few beers, probably cut it in half. My experience has been that you become a much cheaper date, to put it that way, is that alcohol hits you harder. It tends to affect your balance more. It makes you tired more easily, particularly when in conjunction with the medicines that I use for Parkinson's disease. And this is all of them, from levodopa to Mirapex to you name it. All of them seem to have a similar reaction where people, from what I hear, just aren't able to drink as much as they could. It hits them harder and they have that effect. It directly impacts the cerebellum. And so alcohol directly impacts the cerebellum, which happens to be the area of your brain that controls gait, balance, and coordinated movement. And as most of you out there know, your gait, balance, and coordinated movement aren't good to begin with, or aren't necessarily perfect to begin with. You can imagine that this is going to affect the same areas and you're going to notice more symptoms. Again, I never tell people they can't drink, but boy, do you have to be really careful because it does affect your balance, particularly people who already have balance problems. And so you really have to be careful and stay upright. Falling is not your friend. You don't want to end up on the ground, and you certainly don't want to end up in the hospital. So again, use good judgment. Do your best. Take it easy. Go slow. If you don't know how it's going to impact you, just try with a little bit and go from there. Those are kind of my recommendations on alcohol. Can pramipexole contribute to dyskinesia when used with Cinemet? Absolutely. Absolutely, they're additive. All of the side effects of carbidopa levodopa are also the side effects of pramipexole, are also the side effects of just about every other medicine that we have. And the side effects are additive. And so when you see hallucinations and dyskinesias and motor fluctuations and all of these side effects to the medicines, it doesn't matter if you're on one medicine, if you're on a combination of medicines, if you're on a few different medicines, they all have the same side effects and all the side effects add up. So you might notice that if you do have dyskinesias on carbidopa levodopa and I add pramipexole to your regimen to see if I can help you move better, less stiff, less slow, less shaky, whatever, your dyskinesias are probably going to get worse. And so this is always things that we have to keep in mind when we're adjusting medicines, when we're adding in medicines, when we're layering in medicines, which we do commonly, because that's also how you try to keep the dosages of each medicine a little bit lower. The side effects are additive. And so if somebody's already having dyskinesias, already having hallucinations, then I really have to be careful when I'm adding in other medicines. Doesn't mean I won't do it. I do. Because again, if somebody also can't move or they're really shaky or they're really stiff or they're not doing very well, we have no choice but to try adding in more medicine, but it comes at the price of potentially exacerbating or increasing the side effects. And so this all goes into the decision-making process when we're trying to figure out what to do with you, when we're trying to figure out what medicine do we add, how much do we add, do we need to just increase your levodopa, or do I need to layer in another medicine? I mean, all of the situation individualized to you is really how we make that decision, but those are all taken into consideration and taken into account. Aricept and Exelon can cause your blood pressure to drop too low. Yep. Unfortunately, a lot of the medicines that I use, including the Parkinson's disease medicines, the memory medicines, with a few exceptions, most of the medicines that I have lower blood pressure. Now, the problem with that is Parkinson's disease also lowers blood pressure. Again, your autonomic nervous system, those receptors don't fire correctly. And so a lot of my patients tend to notice their blood pressure going down. I see a lot of patients who, when they first come to me, they have had chronic high blood pressure and their PCP has them on 1 or 2 or 3 different medicines to lower their blood pressure. But as Parkinson's disease progresses, as we put people on more and more medicine, both the Parkinson's disease drugs and the dementia drugs or the memory drugs, they oftentimes come off of their antihypertensives. Either they lower the dose or they come off of them completely. I mean, so these are things that we have to pay attention to. And this is where I am not a very good primary care doctor. I am actually a fairly lousy primary care doctor. You don't want me being the one who's in charge of your blood pressure or your cholesterol or your diabetes. And so this is where I really do rely on good primary care doctors to help us out, because that's usually who is oftentimes treating hypertension before people get to me. And that's usually where I'll send people to say, hey, can we get rid of this medicine? Do we need this medicine? Can we lower this medicine? Is there something we can do? And so having a good primary care doctor on your team is really helpful, particularly for things that are blood pressure related. Again, it's all Parkinson's disease related, but at the end of the day, they're still better at managing it than I am. And so this is where it really does become a group effort or a team effort. Okay, there's a lot in this one. Donna tries to kill me every time we come on this talk. All right, well, I speak to the motor complications and oxidative stress associated with the long-term use of levodopa. Yes. Is there a maximum amount of levodopa that you can take? Sort of. Has it been proven that levodopa does not cause faster decline of dopamine transport neurons? Sort of. All right, so let me start with this. So Carbidopa levodopa is the gold standard medicine that we have for Parkinson's disease. It is the medicine that we use the most. It is generally almost across the board the first drug that we go to, and usually when people are on it, they're on it forever. It's as close as we can get to replacing dopamine, which we think is lacking in people with Parkinson's disease. I won't get into the controversy there. And it corrects the problem. So it is also the drug that has the best impact on quality of life and the best impact on the motor and non-motor symptoms that we have. So it's literally the gold standard drug. It's the best drug I have. Is it side effect free? Of course not. Are there prices to be paid? Yes. Everything comes with a price. There is no such thing as free magic. There's always a price. There was studies back in the day, we're going back a ways now, that suggested in a cell model that levodopa was toxic to cells, and that using levodopa would lead to a faster decline in cell death on a cellular model level. So this was not in people, this was in the lab. It was thought that levodopa was toxic to neurons. This has not, as far as I know, panned out in actual people. Again, we've been using carbidopa-levodopa for 60 years, and it has not been shown, as far as I know, to be toxic or detrimental or increase the speed of decline in people. But again, there's always that lab studies and suggestion that perhaps it does. And so this has been a lingering question for a really long time. This is not an unheard of or an inappropriate question. As far as I know, it has been as proven as possible, because that's a hard thing to prove, that it does not cause faster decline of dopamine neurons in people. And so again, my line of thinking is that yes, it comes with a price. Yes, you get side effects. Yes, there are problems, but I don't think that it actually speeds up the rate of decline in dopamine producing cells. Again, that there may be a study that comes out in the near future that suggests it does. Again, there was the lab model that suggested it was toxic, and that's where all of these questions came from. So my personal belief is that no, it doesn't speed up the decline in Parkinson's disease, and the decline that you do see is just typical disease progression. Because the other thing it's not doing is slowing down or altering the course. So none of the medications that I have, including surgical interventions, are quote unquote disease modifying. So carbidopa-levodopa is the best drug that I have, but it is not impacting the underlying disease in that it is not slowing it down. It is not keeping you better longer. It is not altering the course. We do not have a medicine that does that. I don't think it speeds up the progress, but it's definitely not declining or slowing it down. And so I think the decline that you do see is typical disease-related progression. But again, you can see how hard this would be of a thing to study. And so I don't know that we can necessarily say it's proven, but it's been used for so long. This is the course that we've seen. I think we've extrapolated from that we don't think it does speed up the progress. I don't think there is a maximum amount of levodopa you can take. And I say that with I don't think, because again, there's caveats to everything. I have patients that take astronomical amounts of levodopa. Is that a great plan? Well, no, probably not, but I have patients that do it. We are generally limited by side effects. So dyskinesias, hallucinations, motor fluctuations, wearing on-off phenomenon, things of that nature. And so I don't think there's actually a max dose. It's just a matter of how much can I get into you before we run into severe or disabling complications. I say there's a caveat here because I have run into pharmacies and I have run into insurance companies who tell me that I've hit the maximum dose of levodopa. I don't know where they came up with the maximum dose. I'm not sure which literature they use to come up with the number that they use, but I have had pharmacists and I have had insurance companies tell me that I can't go any higher. And so is that the maximum dose? Well, I feel like that's an arbitrary number that somebody just made up. But since insurance companies run the world, at least my world, that is a limit. My short answer is I don't think there is a maximum amount that would, either be overdose or toxic, again, outside of side effects. And that's really where I draw the limit in terms of how much can I get into somebody before I run into major complications and side effects. So hopefully I answered those questions appropriately. Those were good questions, but definitely challenging questions as usual. All right, currently taking Cinemet, really bad morning akinesia. How would I treat that? Well, again, I would start by figuring out when it's happening. How's it related to your medicines? If you're having akinesia or bradykinesia, meaning you're not moving very well, then you probably need more medicine. Again, carbidopa, levodopa 3 times per day really isn't that much. So I like to take it up to 4 times per day before I start layering in other things. Sometimes I add a controlled release at night. Sometimes I start with a Neupro patch to smooth out ups and downs. Sometimes I go to Mirapex to see if you need something really strong. Sometimes I'll go with a weaker medicine like Azilect or Selegiline or Norians or one of these other medicines. Sometimes I'll switch Sinemet to Rytari. And so the short answer is there's about 7 ways that I can think of to try to work on this. And this is why it really is in your interest to talk to your doctor and go over all the ins and outs about what's actually happening to figure out the best plan for you. Is your office using Medtronic BrainSense to guide the initial programming when DBS patients get the Medtronic Precept implanted? I believe we are. So I'm not a programmer. So in just for general terms for people who aren't in the know about deep brain stimulators. So when you implant deep brain stimulators, which we do a lot of, again, the leads go in, you get hooked up to a generator in your chest, and this is really where we do the work. About a couple of weeks after you get your surgery done, you come back for your staples to be removed, and that's when we start turning you on. Usually this is done by the nurses in neurosurgery. Sometimes it's my nurse practitioners here. But the short answer is I myself am not a very good programmer. I've taken the courses, I've done it, so it's not impossible for me, but I'm not very good at it. This is one of those things that you really have to do a lot. You really have to do repeatedly, and you do have to do consistently to be good at it. And I have good people here who do it, so it's not in my best interest to be the one who's good at it. I would much rather defer that to somebody else who can do it more consistently. But the short answer is yes, we have been using not just that, but Boston Scientific also has one. There are now programming programs. Sounds a bit weird, but programming programs that really start the initial programming better. They sort of give you guidelines into where we think the optimal target will be, the optimal settings will be, and we can use that as opposed to the way we used to do it, which was kind of go through each one systematically, turn it up, turn it down, go up, turn it up, turn it down. And so that's kind of the old-fashioned way that we used to do initial programming. There are techniques now, there are programs now from a lot of the device companies that really help this. And I do think we are using them to our advantage. Again, I don't think any of that exceeds or is better than the experience of the people that I have here doing it. But I do think people just knew learning how to, adjust deep brain stimulators or program deep brain stimulators. These are really great tricks and hacks that we can use to speed up the learning process. And so, again, thankfully, the people that I have here at Allegheny Health Network have been doing it for 20 plus years. And so they're really good at it. But yes, they are still using stuff like this. And I think as you get more and more people who are learning how to do it, it's really going to be a godsend for helping them. Go ahead, Donna. I see your hand up.
The reason I bring this up is because I attended a Medtronic seminar for programmers.
Sure.
And they said that when they've been swapping out the Activa device for people to the Percept, and if they have the right leads, using the BrainSense brain scan and stuff to verify their programs, and they're finding that they've overstimulated a lot of patients using
you're right.
So that's an opportunity for you to lower your stimulation and then not have as many side effects and lower your battery consumption. But it took that for them to realize what they were doing that. So, and have the programmers that you have they been trained in BrainSense?
Yeah, they have.
All right.
They have. And the other thing we've learned actually through a lot of these things, and I think it was more through Boston Scientific than Medtronic, is they came up with this imaging technique where you could really see if the leads are correctly placed. Now, of course, our surgeons here are perfect and they never miss. And so it's always in the right place. But I think at other places, we're not maybe as accurate as we think we are. And so we're actually learning a lot about, with newer technology and with the deep brain stimulator leads and imaging techniques and again, stimulation parameters and these different programs, we're learning a whole lot of new things that we never even thought about, never even, knew about, back in the day. And so I think you're right. We are going to see a lot more of these things being used. And again, I think all of this is heading towards where I really think we need to be, which is a self-programming DBS. Again, we're not there yet. Every time I meet with the reps, I tell them I want the same thing. I want an all intracranial, self-learning, self-programming DBS. And then they laugh at me and say no. And I say, okay, well, then what do you got? But I do think it's things like this that are steps towards getting to that ultimate holy grail, which is a device that really either uses stimulation or recording sensors, or is able to program itself based on symptoms. And then we get away from even needing somebody to do the adjustments. But again, this is science fiction at the moment, but this is how we get there. All right. Occasionally I wake up choking on my saliva. Can this lead to aspiration? Should I be concerned? Yes, yes, and yes. So aspiration is exactly what it sounds like. Kind of breathing in that saliva or food or whatever. It goes into the lungs. It leads to a pneumonitis or pneumonia, and it is a problem. The hard part about choking, especially when you wake up on it, is it because your swallowing muscles are affected? Is it because you're a pooling of your secretions? That's a tougher one to try to figure out what to do about. I mean, a lot of Parkinson's disease patients, or my patients in general, do have choking or swallowing problems, in which case I get them to speech therapy and we do modified barium swallow evaluations and we test these things. But some people just have excess secretions, excess saliva, in which case maybe, injections or medications might help with that. And so it may be worthwhile getting you to a speech therapist or starting the process and looking into this, because you're right. We don't want you choking. I certainly don't want you ending up in the hospital because of an aspiration pneumonitis or an underlying pneumonia that maybe we could have done something about. And so, yeah, you should bring that up to your doctor, make sure they're aware of it, have them start looking into this and make sure we take care of it before it gets worse. Omron Evolve blood pressure cuff. There you go. Hopefully that answers the question for everybody, because now I know one. So now I'm going to tell, no, I'm not going to remember that name. I'm not going to lie. But if I do remember a name, now I will tell everybody about that one, because apparently it's good. Thank you. Okay. Comment on effectiveness of medication if taken close to diagnosis. I'm on Azilect and amantadine shortly, starting 6 months after my diagnosis. Symptoms of shaking in my hands have not worsened. Am I fortunate that it hasn't progressed, or is it because the medicine was taken? So you're fortunate that it hasn't progressed, is the short answer. So, but this does bring up a good question as to when do we put you on medicine, right? I mean, this is a little bit individualized, but the short answer is it's when you need medicine, which I know sounds silly. Coming back to something that I just mentioned is I don't have a disease modifying medication. I don't have a cure. I don't have a thing that slows it down or alters the course or prevents you from getting worse. Exercise theoretically does that, but the medicines definitively don't do that. Why that's really important is there's not necessarily any harm in waiting to put you on medicine. And I say necessarily because you are missing out on the symptom management, the potential quality of life management. And so these are all things that we think about. Generally, my rule of thumb is if your symptoms are not bothering you, they are not keeping you from doing your day-to-day tasks, they are not affecting your or impacting your quality of life. In other words, they are not disabling you in any way, shape, or form. There is no harm in waiting to put you on medicine. That being said, I have plenty of patients that I diagnose and they say my symptoms are bothering me. They are keeping me from doing things. They are impacting my quality of life and my day-to-day life. And literally, as soon as I make the diagnosis, I put them on medicine. It always comes down to how much are your symptoms bothering you and how much are they impacting everything you want, like, or need to do during a day. If they're not, there's no harm, at least in my opinion, in waiting to start medications. If they are, then it doesn't make sense to ignore your symptoms. And so because I know that neither amantadine, theoretically Azilect at one point was thought to be questionably disease modifying, although that has sort of gone away recently, we're fairly confident that the medicines are not disease modifying. And so if you're still doing great since 2010, you're probably just fortunate, and it probably is not because they put you on the medicine shortly thereafter. However, if your symptoms were bothering you, I also would have put you on medicine, and I would continue you on medicine, particularly because you're doing well. So that's how I would kind of answer that question. Oh, Donna, you're going to have to teach me this one too. The 10 minutes per day, 10 hertz square wave sound therapy to reset your brain waves and open the gates for dopamine flow. You want to send me the link? I'm going to have to read about it. I don't know enough about that to comment on it, but it sounds interesting. Anything based out of NASA sounds interesting. So send me the link. I'll look at it and I will get back to you next time. Does that sound fair?
Yeah, this was my latest. This was a recent thing that I read about that really sounded fascinating to me because, and this goes along with all these vibration techniques, the gloves, Q that sits on the sternum,
Yep.
or vibration techniques, and they're all talking about specific frequencies and getting to the brain through meridians in the body or through hearing, or you put the Q device on your sternum, and it just sounds like it, and it's not constant. It's for a certain period of time to get your brain back in sync,
Mm-hmm.
retrain it. And that's why I question DBS, which is constant at very high frequencies. And they say that they're counteracting these low frequency potentials in brain sense. But what are those really caused by Parkinson's? I don't know. But this is stuff that's coming out that's saying you have an electrical problem. It's not chemical. And it's not really a lack of dopamine. You have the right dopamine in your brain, but it's the flow that's being stopped. The dopamine neurons that are actually getting the dopamine out of your brain, the ones where the brain it's storing dopamine. So, and the DAT scan really is just measuring dopamine flow. It's not measuring actual dopamine in your brain. Is that correct?
Correct. It is not quantitative for dopamine at all.
So I'm starting to believe that Parkinson's is a reset of frequencies in your body. But
Well,
this is the new thing that I found out, and I will send you the research when I find it exactly. This is just a blurb, but
send it to me. And I think you make some interesting points there that I've asked plenty of people and nobody really has an answer. And so here it is. So we know through slicing open people's brains with Parkinson's disease that the cells in the substantia nigra go away. So that's where we got the idea of the dopamine deficiency, right? So if you slice open somebody's brain with Parkinson's disease and you stain the substantia nigra, it's called the substantia nigra for a reason. It's supposed to be black and it's not. And that was the first thing we found. So that goes back 60, 70 years ago. That goes back to 1968 and 69 when we came up with carbidopa levodopa. Now, fast forward to the deep brain stimulator, right? So theoretically, the deep brain stimulator is not increasing dopamine. So how does it work? Well, through recordings, we know that you get abnormal circuitry in your brain. So you normally have a firing pattern in the 30 range. In people with Parkinson's disease, it's about 13 or 14. And this is what we found through recording, which is exactly why they invented this part of the deep brain stimulator. And we think that through stimulating, we can reset these circuits to the correct firing pattern. And that in turn helps with the symptoms of Parkinson's disease. And you're right. They're actually looking now in DBS, can we get away with much lower frequencies or currents and periodic use? So it stimulates for a while and then it's off for a while, because we know through a lot of these devices, there is carryover and you don't have to stimulate constantly. And maybe that's the wrong idea. You're right. There's tons of research being looked at this right now. Dr. Tomich, who's my neurosurgeon here who does a lot of my DBS, is very interested in a lot of these things. And then you throw on top of it, we know that in Parkinson's disease, you get Lewy bodies, right? So alpha-synuclein is in here somewhere. Alpha-synuclein is this protein that misfolds and collects in things called Lewy bodies that are prevalent in patients at autopsy on pathological staining and scans in brains of people that have Parkinson's disease. And so I've often asked, is it a chemical problem? Is it an electrical problem? Or is it a protein problem? Or is it all the above? And which one came first? Now, if you think about it, the easiest one of those to find is the dopamine problem, because back in the day, 70 years ago, the best you could do was cut open somebody's brain and stain it. And so is that really the problem, or is that just the first one we found because that's what we had the technology to find? Fast forward to Lewy bodies, that was found afterwards. Again, this is pathological staining. Is that really involved? Again, there's plenty of controversy into whether or not alpha-synuclein is the problem or a byproduct. Just listen to Alberto Espe from Cincinnati. Boy, does he have opinions on all of these things. Is it really an electrical problem? And all of the rest, the loss of the cells that make dopamine or these misfolded proteins, come because the electricity is not firing correctly? The short answer to all of those questions, which again I've brought up, nobody knows. We don't know yet. Which comes first? What is the real problem? What's secondary? What comes last? If we ever figure out the answer to that question, I think we have a much better way to try to work on this and fix it. But today, I do not think we know the answer to that question. And it comes down to all the stuff you just mentioned. And so I think the research in these areas is very fascinating. And the more we learn about them, I think the better we're going to be able to figure out how to try to help people do better.
Just one thing, Doctor.
Go for it.
When they did the brain autopsies from the brain banks, was it a lack of dopamine or the dopamine transport cells? Because I thought there was a sufficient amount of dopamine left in the brain.
Maybe. So the DAT scan measures the dopamine transporter, but what they were staining for when they sliced open brains were the cells in the substantia nigra that produced dopamine. And so that's where that idea came from. We could talk about this all day, but I'm not going to because there's other questions that I want to answer. But definitely send me that NASA thing because I want to take a look at it, and I'll get back to it next time. Question about this is an interesting question. So I have a question about diet. Would you recommend a vegetarian or vegan diet? No. And yes, I say that with a question mark. So unknown, let's just put it that way. So there are pluses and minuses to vegetarian and vegan diets versus traditional diets, but I don't know that any of those have ever necessarily been compared or contrasted in people with Parkinson's disease. The only data that I know of that I remember offhand was about 2 years ago in my journal that I did a whole journal on diet in Parkinson's disease. And their conclusion was that the Mediterranean diet is the best diet. Now, that's not really that surprising. Theoretically, the Mediterranean diet is the best diet on the planet for everybody, with or without Parkinson's disease. So I don't think that was a stretch. I think we all kind of saw that and we're like, well, yeah, that makes sense. And that is not either a vegetarian or vegan diet, I don't think. Generally, it is lower in red meat. It is lower in processed foods, but I think there's still some in it. It's definitely high in fish. It's definitely high in legumes, fruits and vegetables, olive oils, things like that. But I don't think it is the Mediterranean diet is strict vegetarian or vegan. And so at the end of the day, I don't really know how to answer that question. Now, I've also looked at the blue zones. So the blue zones is something that I'm interested in because I want to live to be 100. I don't know why I have it in my head that I want to live to be 100, but I've had that in my head pretty much since I was a kid. And so the blue zones are these areas in the world that people tend to live to be 100 more than they do anywhere else. And if you look at the diets that they follow, again, similar ideas. They are usually lower in red meat. They are usually low in processed foods, sugary foods, high, all the stuff that we like to eat foods, unfortunately, and they are high in things like olive oil and fruits and vegetables and greens and beans and things like that. So theoretically, and again, that does tend to lend itself more towards vegan and vegetarian, but I don't know that I would necessarily recommend it. If you want to do it, knock yourself out. Who am I to tell you what you should or shouldn't eat? But I don't think there's enough data necessarily for either of those specifically for me to say that's a great idea. Should you push your doctor to tell you what type of Parkinson's you have? I'm going to come back to that in a second. And how do you find that out? And what stage you're in? Ours said they prefer not to classify you. So for a long time, Parkinson's disease was split into tremor predominant or akinetic rigid, which theoretically, at least according to old literature, people who were less shaky but more stiff did worse. I don't think that's necessarily panned out in newer studies or in relooks at old data. And so generally we don't classify the different types of Parkinson's disease because at least from what I remember reading, that really hasn't panned out for who does well, who doesn't do well, and what to do about it. The same thing is true for the staging system. I am also somebody who is not a big fan of talking about what stage are you in. Everybody wants to know what stage am I, but realistically, after I explain it to them, it really doesn't help us. And here's why. Yes, there's staging systems. Probably the best one or most well-known one is the Hahn and Yar. This was a couple of doctors, I think, up in Yale who came up with this staging system. And it's 1 to 5. 1 being just one-sided symptoms, 2 being both-sided symptoms, 3 being some balance problems, 4 being worse balance problems, 5 being bad balance problems. Why I don't label people or talk about the stages very well is it's not that useful of a system for day-to-day practice. It doesn't do anything to tell me what to do with you or what to do for you. And the reason is it's not a linear scale. So the time between stage 1 and 2 is not the same as between 2 and 3 or 3 and 4. Most people live in 3, which is bilateral symptoms and some balance problems or some gait changes for pretty much most of their lives. Not everybody makes it to 5, and so it's not a perfect scale. It's really useful for research, right? When you're trying to compare 2 groups of people, you want to make sure the 2 groups are fairly equivalent to compare. You don't want to put all your really, really sick and difficult and doing poorly Parkinson's disease patients in one group and all the people that are doing great in the other group. That doesn't make for a very good study. And so it is a scale or a staging system that we'll use to try to make sure our groups are equal or fairly equivalent in studies. But in day-to-day practice, it's not all that beneficial. And so that's why I'm probably like that person where I don't lend a lot of credence to what type of Parkinson's you have, what stage you're in. None of those really help us decide what to do in terms of how to manage you. So again, I'm kind of on board with whoever it is that takes care of you. um, I talk about it because people always ask. They say, oh, what stage am I and what's going on, and then I explain this all to them, but I don't think it's really all that helpful. um, Please explain the procedure I mentioned involving the intestine. So there is something called duopa, and I promise I won't go too late, but I'll see what kind of questions I can answer. So there is something called duopa, which is intestinal infusion of levodopa. The long story short is, for a lot of people who have these ups and downs during the day, they made a gel formulation of levodopa that can be directly pumped into the small intestines for 16 hours during the day. And actually it has a lot of benefits to it. So it turns out a lot of the side effects that come from levodopa come from the fact that we give it in a pulsatile nature. Not surprisingly, normal people do not spit out just tons of dopamine 4 times a day. That is not actually a natural or physiologic way to replace dopamine. And it turns out that pulsatile nature, giving you a burst of dopamine and then letting it wear off, is exactly why we lead to a lot of side effects. And so the intestinal infusion actually does a great job of controlling a lot of those side effects, managing symptoms throughout the day. However, everything comes with a price, as I keep saying. The price is you have to have a tube put in, you have to have a pump, you have to know how to take care of it. The tube itself comes with a host of complications. And so in my experience, I've only used this twice in the 10 years that I've been doing this. And each time it was okay, but at the end of the day, there are challenges to using this type of a pump. I'm not against using it, and I'm not against trying it in the correct person, but that's why you really haven't seen it used all that much, because as neurologists, we're not very good at taking care of tubes. My patients in general are not a fan of tubes, and that's really where the limitation is. But that's the idea behind the procedure that I was talking about. If you don't have a tremor and are probably in stage 3 heading into stage 4, does that mean you probably won't get that? It can come later. I've seen patients who do develop a tremor later in disease progression. So even if you don't have a tremor right away and you're really more the stiffness kind of person, doesn't mean you won't be getting a tremor down the road. All right, last 2 questions. So everybody stop typing. Otherwise, my wife will kill me if I don't come home and take care of some kids. Do I have any experience with the skin biopsies that claim to be able to determine the subcategory of Parkinson's done by SIN1? No. I've heard of them. There's been skin biopsies. There's been saliva biopsies saliva samples. There's been cheek samples. There's been a lot of different ways to try to both diagnose Parkinson's disease and classify it. I have not put any credence into it. I haven't used it. again, my experience is that what type you have or trying to subclassify these things is not all that beneficial, at least right now. The same thing is true for genetics, right? Finding out that you have a genetic variant that is leading to Parkinson's disease does not help us treat you right now. However, if and when we get to the point where we are doing precision medicine, which is you are the patient, I figure out exactly what is wrong with you, and I go to the closet or the cupboard or the medical or the computer, and I find the specific treatment for your specific problem. That's pretty much the definition of precision medicine, which is the goal. Once we start getting closer to that, then yes, then maybe I do need to know the subtype, or I need to know the genetic makeup, or I need to know what specifically triggered this, because then maybe the treatments are different. To date, that's not the case. And again, that's what really everybody is working on, right? That's the biomarker that the Michael J. Fox Foundation came out with the spinal fluid biomarker. These are all really important first steps to get us to the point where we are able to do better precision medicine. But since I don't have that readily available to me today, it's not that important at the moment. All right. I don't know why they don't do it overnight in terms of Duopa, in all honesty. I think because nobody wants to wear the pump and it can get dislodged and things like that. That's my guess, but I'm not sure the answer to that question. Last one. I know that constipation is a big issue with Parkinson's. What makes it change from long-term constipation to frequent diarrhea, soft stools? Good questions. And so that's a tough one. I'm not entirely sure. You do get continued gut changes throughout the progression of Parkinson's disease. What I actually probably see the most is you get constipation that actually builds up, and then you get something called overflow diarrhea, which is you get your gut trying to work around a blockage or constipation, and that actually turns into diarrhea. I'm not sure if that's the case all the time, but I have seen people who kind of fluctuate between these things. And the long story short is you just have to work on what you have going on. A lot of times the bowel problems are very difficult, and so I do refer to gastroenterology all the time. And that's kind of what you have to try to work on. Again, I don't have an easy answer for that question or why it happens, but it does indeed happen. All right, Christine, I think I went over my time. Whatever, I don't care. And so at the end of the day, I'm also glad to be back. We'll try to keep everything on schedule now, and I'll pass it back to you to finish it off.
Great. Thanks for another wonderful session, Dr. Leichliter. I just wanted to mention to folks that we are now live with our Step Forward fundraising event. And you will see some differences this year. In the past, we allowed you to work as a team to raise money. And the complication with that is that we can't thank a team in an appropriate way. And so we'd like to do better at individual fundraising. And so you register by yourself and hopefully reach out to your friends to see if they will support us. Lauren has put up information in the chat about Step Forward and how to register. We will find a way to gather team information if you'd like us to do that and recognize a team and their performance. And you certainly can be present at Step Forward as a team and celebrate your success. But this is our biggest fundraiser of the year. And we are hopeful that you all are comfortable reaching out to your friends and family and neighbors and loved ones to support our local efforts in Pittsburgh. I will leave it at that. Thanks, everyone.
All right, guys, we'll do it again next month. Keep sending the questions in. I'll keep answering them. Have a good month.
You too. Thank you.